Well, hello everyone, and welcome back to our multiple sclerosis continuing medical education series. My name is Lucas Kipp, and I'm a clinical assistant professor and MS specialist here at the Stanford MS Clinic in Palo Alto. In our last lecture, we discussed MS therapies, emphasizing the use of high efficacy treatments early in the disease course, as well as concepts in monitoring MS disease activity and our goals of treatment. Today, we will conclude our lecture series on a highly positive note, focusing on that exciting research and novel therapies that are really at the precipice of transforming our field and MS patient care. By the end of this talk, I hope I have illuminated some of the gaps in our treatment landscape, but left you optimistic that by understanding the unique pathologic mechanisms at play in this complicated disease, that we can develop effective therapies to make this chronic, disabling condition one for the history books in the not so distant future. Now, the National MS Society's research priorities are a great way to organize today's talk because they underlie the three fundamental pathways that we're actively pursuing to cure this disease. And we're going to touch on each of these during today's lecture, beginning with stopping disease progression. Now, to stop disease progression, we must understand the immunopathologic processes that are happening throughout the stages of the disease. So I want you to recall this illustration from our third lecture on the different phenotypes of multiple sclerosis. And in particular, I want to draw your attention to the progressive forms of MS. That is, MS characterized by this slow accumulation of disability, which may occur from disease onset, like in primary progressive MS, or that comes after a period of relapsing disease. And here we call this secondary progressive MS. Now, in both forms of progressive MS, disability is worsening, and that's really independent of new clinical relapses or new evidence of ongoing inflammation on conventional MRI. However, what we do see, and depicted by the yellow line, is that we see ongoing brain volume loss or brain atrophy, which is one proposed explanation for this clinical worsening that patients experience in these progressive forms of disease. Now, I also discussed the topographical model of MS to really introduce that concept of neurologic reserve. That is, the finite capacity of the central nervous system to compensate for injury and to remodel itself, and how ongoing brain atrophy is a major player in this dwindling reserve that's characterized by those lowering of water levels in these illustrations. And when that neurologic reserve comes out or is reduced to such a level, that's when progressive disease starts to occur. And so, recalling these concepts, what I'd like to do is dive a little bit deeper into some of the proposed pathologic mechanisms by which this progressive clinical deterioration and brain volume loss may be occurring. Because all of these mechanisms are potential targets for novel therapies for what had previously been called untreatable forms of MS. Now, this figure depicts those proposed pathologic mechanisms of progressive MS. And while there's certainly overlap in a number of these processes, like inflammation and axonal loss with relapsing remitting disease, the pathways in progressive MS are more complex or more diverse. And we'll touch on a few of these pathways today with a particular focus on compartmentalized inflammation, including microglial activation, contributing to axonal loss, which is really that main component of progressive brain atrophy. So to contrast what is happening in progressive disease, first we have to recall what's occurring in relapsing disease. So in this stage, there's this breakdown of the blood-brain barrier, and development of inflammatory aggregates in these eloquent areas of the central nervous system. So, this inflammation results in the patient's experience of symptoms, which we call a relapse. And how they appear on MRI is as these gadolinium enhancing lesions here. And they gadolinium enhance around the time that they develop. But over time, downstream events lead to the loss of oligodendrocytes, those are the myelin producing cells. And so subsequently, we lose the myelin sheaths. You also get axonal loss. When you've got a denuded axon that doesn't have myelin on it, they tend to die. And you also get these astrocytic scars, which in the long term appear as these permanent demyelinating plaques, which are really the hallmarks of relapsing disease. Now, in progressive forms of MS, we typically don't see these gadolinium enhancing lesions in the white matter on conventional MRI, which is what I just showed you on the past slides. In fact, new typical lesions like that generally stop showing up in progressive MS, but yet the brain volume loss is still happening. So is there still inflammation occurring, and where is it coming from? So with ultra high field 7 Tesla MRIs and some advanced MRI sequences, we've actually been able to identify inflammatory infiltrates in the leptomeninges, even when that blood-brain barrier is closed. And that's what I've tried to depict in this first image here. And so you can see that right on the surface of the brain where these meninges would be covering, you can see this area of enhancement. Now, these meningeal aggregates, they resemble what are called tertiary lymphoid follicles, and they're densely packed with B cells, which have been hypothesized to maintain a local compartmentalized inflammation that's smoldering the brain from the outside in. And new MRI sequences, such as double inversion recovery, which is this sequence here, have also revealed a very high prevalence of cortical lesions, particularly in progressive forms of MS, which is something we cannot see on the typical MRIs that we get in clinical practice. Now, interestingly, putting these two kind of discoveries together, we've shown that these meningeal infiltrates that are outlined in these green dots here, they actually overlie many of these cortical lesions that are depicted in blue, and particularly subpial lesions that are right on the surface of the brain, which I'm showing you here. So what we're really seeing is demyelination of this very superficial part of the cortex that's proceeding inwards, and it's possibly associated with this overlying inflammation in the meninges. And as I mentioned, it's this compartmentalized inflammation that's occurring behind the blood-brain barrier that appears to be happening, independently of that peripheral inflammation that we see in early relapsing MS. And it's certainly contributing to that slowly progressive brain volume loss. And it might also explain why our traditional MS therapies, which do not cross the blood-brain barrier, are generally not effective in progressive MS because they aren't getting at this type of chronic inflammation. However, we've got a number of novel therapies that are utilizing small molecules that are in development to target this inflammation, which we're going to discuss a little bit later. And also, the presence of these B-cell rich follicles also suggests that therapies targeting B cells, if we can get them in there, they should be considered as a possible strategy to control the disease. And that's being done as well. So the other ongoing inflammatory process we see occurring in progressive MS are what are called chronic active lesions. So while those T2 hyperintensities that we see form in relapsing MS, on the outside, they appear to be kind of relatively static in size. But if you kind of watch them on the same scanners with the same sequences over time, it turns out that about 57% of them show actually persistent inflammation with a ring around them that continues to expand, even when they no longer have that characteristic gadolinium enhancement I showed you earlier. And we call these chronic active lesions. And so pathologically, what we see is that they have a rim of iron-laden macrophages. So this is iron, and this is the microglia and the macrophages that are surrounding the periphery of a lesion that's already been demyelinated at the core here. But there's this slow rate of peripheral ongoing demyelination and axonal loss. And recent improvements in MRI technologies have allowed us to identify and quantify these chronic active lesions in vivo as well. So the first image here on your left is an axial T2 flare, and it's just showing those typical lesions in the periventricular white matter that generally form in kind of early relapsing disease. But in the next picture, this is a sequence called susceptibility weighted imaging. You can see that some of those lesions have a rim, a dark rim around them, a hypointense rim. And so combined pathologic MRI studies have consistently demonstrated that these chronic active lesions show what is called this paramagnetic rim. And so we call these iron rim lesions because what they're reflecting is that rim of the iron-laden microglia that are at the edge of those chronic lesions that I just showed you on the prior pathology slide. And so these lesions show a very slow but gradual increase in size and hypointensity, meaning they get darker and they get bigger over many years. And the nice thing about this is that we can actually see this expansion now that we know to look for it on just conventional T1 weighted images. And we call those slowly expanding lesions. So it's just a way to visualize on MRI these chronic active lesions. And that expansion, it's a reflection of ongoing demyelination and axonal loss that's then further contributing to brain atrophy. Now, these slowly expanding lesions, or SELs, they are much more prevalent in patients that have progressive MS. And like those meningeal aggregates that I just showed you, these SELs have been proposed as another biomarker of chronic inflammation in progressive MS. So to summarize, what I've shown you is that there are additional forms of chronic inflammation occurring in progressive MS, which we can now visualize on MRI with leptomeningeal follicles kind of on the surface, and also these slowly expanding chronically active lesions. And it is this chronic compartmentalized inflammation that's likely responsible for much of the reduction in brain volume loss and subsequently worsening of clinical disease and symptoms in progressive MS, for which no current immunotherapies have a significant effect on. So now that we understand and can visualize these novel pathologic processes, we can begin to develop novel therapies. So one of the ways we might target these processes that are behind that blood-brain barrier is by getting drugs across that barrier. So ibutalas is one such drug. It's an oral small molecule that can cross the blood-brain barrier. And in a recent phase 2b trial called the SPRINT MS trial, the results of which I'm showing here, which looked at patients with primary progressive and secondary progressive MS, given ibutalas versus placebo, it showed a 48% reduction in the rate of whole brain volume loss over the nearly 2 years of the study. And interestingly, the study didn't show that it had any effects on conventional measures of inflammatory activity. So those new lesions, forming in there was no effect on that. So it really suggests that the favorable effect of ibutylast is really probably neuroprotective. And so a phase 3 clinical trial is currently in the works uh, to see if this is going to be effective treatment for progressive disease. So another class of small molecules are called Bruton's tyrosine kinase inhibitors, and they're really taking the MS field by storm right now. So these are also brain penetrant medications, and they've got the potential to help both relapsing and progressive forms of MS. And that's because of the way that they work. So these drugs are thought to inhibit B cell activation and cytokine release. And we know that B cells are key drivers of both the acute and chronic inflammation within the central nervous system. But we also know that these medications inhibit macrophage and microglial activation, what's happening at the peripheral rim of those chronic active lesions. And so these may play a significant role and kind of a dual purpose in both acute and chronic inflammation in MS. And we don't have to wait that long for answers. So this is a table of the currently active phase 3 clinical trials for BTK inhibitors, and there's a number of them. And I've put some arrows here just to show that these are the studies that are being done in progressive MS right now. And some of them are reading out as early as 2024. And here at Stanford, we're currently recruiting for what's called the FENHANCE phenibrutinib trial. Now, another strategy is to develop methods to actually shuttle big molecules, such as monoclonal antibodies that are so effective at treating relapsing disease. Can we find ways to shuttle these large molecules across the blood-brain barrier? Because only about 0.1% of monoclonal antibodies that we administer via IV, so these are drugs like natalizumab, rituximab, ocrelizumab. These are some of our most effective MS therapies for the early relapsing disease. Only about 0.1% of them actually get into the brain. And so there's numerous strategies that are depicted here about how we might do that. But the one I wanted to focus on is this first one. So it's an example of a bispecific antibodies that are meant to trigger what's called receptor-mediated transcytosis. Now, receptor-mediated transcytosis is one of the principal pathways by which the brain already naturally transports big molecules that are essential for brain function across that blood-brain barrier. And so what we've identified is receptors that are already in the brain that if we activate them, they can trigger this transcytosis. And the one that is used most in development is this one called the transferrin receptor, depicted here. So to create a bispecific antibody, all you need to do is take a therapeutic antibody, like an anti-CD20 B-cell therapy, like ocrelizumab, for example, and then you combine it with an antibody that will activate that transferrin receptor, because then you can trigger that transcytosis process to pull that drug that you attached to it into the brain. And this is exactly what Roche has developed with their brain shuttle technology. And so the hope is that by bringing these therapies into the central nervous system, particularly B-cell therapies in this brain shuttle, these anti-CD20 therapies, that will be able to eliminate those B-cell predominant meningeal follicles that are contributing to that chronic compartmentalized inflammation in progressive MS. And so a phase 1 clinical trial is currently already underway at selected sites, including ours at Stanford. So as you can see, by understanding the pathological processes in progressive MS, we're already well on our way of testing therapies to truly stop disease progression. Now, shifting gears, I'd like to address another unmet need in the treatment of MS. And that's really the need to restore function, not just stop it or halt worsening. And the way we're going to do that, hopefully, is through neuroregeneration and repair. Now, developing restorative therapies requires an understanding of human myelin. So this picture is really just to show how myelin develops into a mature oligodendrocyte. So it begins with these precursor neural stem cells. They develop into what are called oligodendrocyte precursor cells, or OPCs. Then they differentiate into what are immature oligodendrocytes, which can't quite make myelin. And then finally into these myelin producing oligodendrocytes. You can see their processes that are wrapping around the axons there. Now, these OPCs are not just something that we have in development, but they actually persist in adulthood. So about 5 to 8% of all the cells in our central nervous system are actually these OPCs. So after demyelination occurs in processes like MS, we can make new myelin either from oligodendrocytes that are synthesized from those OPCs that are kind of waiting in the brain to differentiate, or by the neural stem cells. And pre-existing mature oligodendrocytes, so the ones out here, they can also extend their processes to form new myelin sheaths to remyelinate axons. So keeping this in mind, intuitively, there are then some strategies for which remyelination may occur. One, we could recruit or make more mature oligodendrocytes so they can make more myelin. We could stimulate mature oligodendrocytes to make more myelin. We can block processes that prevent remyelination. And I'm going to give an example of each of these in the next few slides. Now, one of the ways that we can find potential pro-myelination molecules has been with large high-throughput assays, which has come with advances in technology. And these strategies have really led to the identification of numerous promising compounds that have either been repurposed from something that's already on the market but used for a different disease, but also new compounds. And all of these really target very diverse pathways. And it may sound like science fiction, but these molecules are already being tested in humans. And this table is just meant to depict the forerunners of these remyelinating therapies that are already in at least phase 2 clinical trials, a few of which I'll talk more in depth. In particular, Opicinumab, or anti-lingo 1, Clemastine fumarate, and also transorbital electrical stimulation. So going back to our first strategy, we could potentially remyelinate by making more mature oligodendrocytes. And so one example of a promising remyelinating agent utilizing this strategy is actually the over-the-counter antihistamine called Clemastine fumarate, which is commonly used to treat allergic rhinitis. So this is an example of one of those repurposed compounds, and its thought is that it enhances the maturation of immature oligodendrocytes to the mature myelin producing oligodendrocytes, and that's independent of its antihistamine effect. And there's already been a clinical trial, phase 2 clinical trial of this called the REBUILD study, the main results of which I depict here. And so this was a randomized, controlled, double-blind crossover trial of Clemastine versus placebo in relapsing remitting patients with chronic optic neuritis. So group 1, which is in blue, they were given Clemastine for the first 3 months and then crossed over to placebo for the next 2 months. And group 2, the red line, was given placebo for 3 months and then switched on to Clemastine for the following 2 months. And what you can see is that, both groups, when they were on treatment, that the latency of their visual evoked potentials, or rather the time required for a visual signal to travel down that optic nerve, was reduced, which was the study's primary endpoint. Presumably, that's due to remyelination of that optic nerve, that the conduction velocity, the signals are getting to the brain faster down a nerve that presumably you've healed up a little bit. Now, are these results truly a reflection of remyelination? And, you know, can these findings be extrapolated to other areas of the central nervous system? Well, that's yet to be determined. But there is a follow-up phase 2 study called the RECOVER study that is also exploring Clemastine's effects shortly after more acute optic neuritis. So this is exciting stuff. Now, the second strategy was, can we find a way for oligodendrocytes to just do more myelinating, ones that are already there? So previous experimental studies have shown that if you stimulate neurons, that promotes myelination in the mammalian brain, and that electrically active axons are actually preferentially myelinated. So, utilizing this knowledge and the accessibility of the optic nerve, researchers are currently enrolling in what's called the OnStim study. And they're using a device called the iTronic Next Wave to study the effects of transorbitally stimulating the electricity, the optic nerve, on remyelination after an acute optic neuritis. And so in this trial, study participants are putting on this set of stimulation goggles, and there's some electrodes here that are stimulating that optic nerve. And so the hope is that by stimulating that optic nerve, electrically, that it will promote remyelination and then decrease the latency of those visual evoked potentials. Now, finally, we could also help with remyelination if we inhibited whatever processes might be preventing myelination in the first place. And to this end, researchers have identified a protein called LINGO-1 that's expressed on neurons and oligodendrocytes that actually prevents the maturation of OPCs into these myelin-producing oligodendrocytes. And so they've developed a drug called Opicinumab to actually block this inhibitory protein. And there's been 3 trials so far with this molecule in humans. So the first was called the RENEW trial, and that was in people with optic neuritis. And they showed shorter visual evoked potential latencies, in other words, improved conduction velocities along the optic nerve. But it was only in a per protocol analysis that I've depicted here with the purple star. Now, the second trial, called the Synergy trial, looked at 4 different doses of Opicinumab in relapsing, remitting, and secondary progressive MS patients. And it showed some benefit with these middling doses, but it didn't meet its primary endpoint. It's a little unusual that, the lowest dose and the highest dose didn't really have an effect, and the middling doses, did. So, this was considered a negative trial. But ultimately, the company proceeded with another trial called the Affinity trial in patients with relapsing remitting MS, utilizing the dose that had the strongest effect on previous trials, and also recruiting patients that were most likely to respond. And that was based on these prior trials showing that younger patients with earlier disease were more likely to get an effect. But this trial was actually halted early when the results of part 1 didn't actually show a sustained significant functional improvement or any halting of disability progression. But I think despite these negative results, it speaks to how far we've already come in our approach to these remyelinating therapies. The fact that we're already testing molecules in humans, which was really unheard of, even 10 years ago. But I think it's also clearly taught us that there's a lot more that we have to learn. So in the last few slides, we're going to talk about ending MS forever. In other words, preventing MS in the first place so that there aren't any new cases. But to do this, we've got to understand the relevant risk factors for MS and the pathways by which these risk factors lead to the initiation of the disease. So as I discussed in our first lecture, the Epstein-Barr virus is a type of human herpes virus that has consistently been shown to be associated with increased MS risk, both in adult onset and pediatric onset MS, in different races and ethnicities. Nearly 100% of people diagnosed with MS have evidence of prior Epstein-Barr virus exposure that's indicated by the presence of antibodies to EBV in their bloodstream. And while a portion of the general population is also EB positive, a large portion, people with MS also have higher titers of the antibody, particularly those to what's called EBNA1. And while most EBV infection occurs during childhood and is asymptomatic, clinically symptomatic infectious mononucleosis, which is caused by the EBV in adolescence and adulthood, doubles the risk of MS compared to the general population. So there seems to be a time frame when you get this infection, and if you get symptoms from it, that also influences your risk of getting MS down the road. Moreover, having a higher titer to that EBNA1 antibody and this history of symptomatic infectious mononucleosis is a bigger risk factor in those that also carry genes that increase MS risk. So, or if people are obese, which from a prior talk we know is another risk factor for developing MS. So it kind of seems like there's this perfect storm of underlying risk factors that could potentially be triggered like by a virus at a critical time point, like in adolescence or early adulthood. Now, most people, however, that are infected with this really common virus don't go on to develop multiple sclerosis. So causation has not been proven. However, two recent studies greatly support its role in the pathogenesis of MS and really provide some new insights in developing preventative MS therapies. So the first is this paper out of Harvard from Science, using data from 10 million young adults on active US military duty who were monitored twice a year for over a 20-year period. And what was determined is that MS risk increases 32-fold after EBV infection. They also showed that concentrations of what are called neurofilament light chain, which is a biomarker of neuroaxonal degeneration, and it's a marker of kind of MS before you get symptoms, that also only increased after EBV infection. But despite this strong association, epidemiologically, no studies had shown pathologically, well, like how does EBV actually trigger multiple sclerosis? Until about 2 weeks after the Science paper came out, when our group at Stanford published the second article in Nature. So long suspected to be due to molecular mimicry, we were the first to show that people with MS had antibodies to both the EBV protein, so that's the EBNA1, but that it cross-reacts to a protein that's expressed in cells in the myelin sheath in the brain and the spinal cord called glial cam. So the idea is that, the Epstein-Barr virus exposure, you develop antibodies to EBNA1, which are on EBV, but simultaneously, you're also developing antibodies to a protein that's on the myelin sheath in your central nervous system. And so even when the virus is eliminated, that process can still be ongoing. So together, these two studies really offered some of the strongest evidence for EBV as a cause for multiple sclerosis. And it also suggests that a proportion of MS cases could be prevented in the first place if we stop EBV infection, like with vaccination, for example. And understanding this pathway now also provides some new targets for therapy for those that already have the disease. Can we eliminate cells that have already been infected by EBV? And so while the strong data of the role of EBV in MS is relatively new, a prophylactic EBV vaccine aimed at prevention of primary EBV infection has actually been in development for more than 30 years. And that's because EBV isn't only involved in autoimmune disease like MS, but it's strongly implicated in numerous other conditions, including infectious mononucleosis, which we talked about, but also multiple types of both lymphoid and epithelial cancers. So there's a good reason to want to prevent this, not just from an MS perspective, but multiple other diseases where EBV is playing a role. And so while none of these vaccines have yet been licensed, the rapid and successful development of mRNA vaccines for COVID, has really encouraged the development of mRNA EBV vaccines as well. And in fact, Moderna has already initiated the first in-human phase 1 clinical trial of its mRNA EBV vaccine in healthy adults aged 18 to 30 years. So we're talking, primary prevention of EBV and thus potentially preventing MS in the first place. And these vaccinations are already in the works. Now, as I mentioned, therapies are also currently being tested in humans to eliminate those cells that are already infected with EBV. So this is just basically a screenshot from clinicaltrials.gov of the EMBOLD study. And it's testing an investigational T-cell immunotherapy administered via IV, which targets EBV-infected B cells and plasma cells, which we know from the prior slides have been implicated in both acute, relapsing, and progressive forms of MS. And this trial has already reached its target enrollment of 80 progressive MS patients. And we're going to get the results as early as October of 2023. And the prior phase 1, including an open label extension, indicated that not only was this drug well tolerated, but most people's disability scores stabilized or improved. And for those participants that actually showed improvements in their disability scores, simultaneously saw that they had larger increases in the density of their myelin, which we're now measuring by something called MTR on MRI. It's thought to be a really promising surrogate marker of myelin loss or repair. So this may suggest that regeneration of the myelin sheath has occurred in the brain of these participants whose disability actually got better following this treatment. Our own Dr. Larry Steinman was the primary PI for this study, and we enrolled patients at Stanford for this as well. So really, really exciting stuff. And I know that this was a whirlwind of information, but I hope you have seen that by understanding the immunopathologic pathways in progressive MS, we've got more than a fighting chance of stopping disease progression. The identification of these chronic compartmentalized inflammation in the CNS, as visualized by these inflammatory meningeal follicles, the iron rim lesions, the slowly expanding chronic active lesions with these activated microglia, all of this really offers novel targets for therapy, which I've just shown you are already in development and well on their way. Likewise, we're already testing remyelinating therapies to restore what's been lost by developing molecules to stimulate more mature myelin producing cells, more myelin production from existing cells, or creating a more hospital environment for remyelination. But obviously there's still a lot of work to be done in really understanding the complexity of this process, as noted by what I'd say is a failed attempt of that anti-LINGO-1 molecule. But I think perhaps the most exciting developments have come this year with our advanced understanding of the role of EBV as a trigger for MS, with both a prophylactic EBV vaccination in the works and also a therapy directed at EBV infected cells. Really trying to stop new cases of MS in the first place and really ending MS forever. And so with that, I'll just click through my references here and say thank you very much.